Welcome back to the deep dive. Now, if you're a GP trainee, maybe a medical student getting ready for that big AKT exam, well, this deep dive is absolutely for you. We've got a whole load of source material here, all focused on ocular red flags, urgent management, and our job today, really, is to pull out the absolute must-know stuff.
Yeah, the really high yield points.
Exactly. We want you to feel confident spotting what needs an urgent referral, what's an immediate admission, and, what you can actually manage safely yourself in primary care.
And that difference is just, it's everything, isn't it? Our sources, they kind of blend emergency protocols with the longer-term management guidelines. It's meant to be a pretty complete guide.
Right.
We're looking at those split-second decisions for emergencies, those subtle signs of systemic disease, think RA, MS popping up in the eye, and maybe the trickiest bit for trainees.
Oh, the neuro stuff.
Yeah, the neuro-ophthalmology. Getting your head around visual field defects and localization, that's tough.
It really is.
Yeah.
And ophthalmology comes up so much in exams, precisely because, well, the stakes are high, aren't they? Clinically for the patient, and let's be honest, for you in the exam. You need that instant pattern recognition. It's more than just memorizing facts. It's about understanding why. Can you, instantly tell painful from painless vision loss?
Oh,
or
blanching versus non-blanching redness.
Exactly. That kind of knowledge.
Yeah.
That's the difference between spotting something self-limiting and missing, something potentially life-changing, like a stroke sign.
It really is about spotting those key clinical pictures, like knowing that a pale retina with a cherry red spot, that screams vascular emergency, needs a stroke workup right now.
Whereas this smashed tomato look.
Exactly. The smashed tomato or stormy sunset suggests a vein occlusion, still serious, but a different kind of agency, different workup. The appearance tells you so much about how fast you need to act. We'll definitely spend time locking those down.
Okay, let's unpack this, starting right at the top with the real ocular emergencies, the ones that need immediate action, immediate admission, the stuff you just cannot afford to miss. Right, first up, the highest risk infection we're likely to see in primary care affecting the eye orbital cellulitis. Our sources are absolutely clear. This is an admission critical condition.
Definitely. It's an infection that's got behind the orbital septum, usually spreading from nearby sinuses. It's serious stuff.
And the danger is, it's huge, isn't it? It can compress the optic nerve pretty quickly, lead to vision loss.
And even worse, it can spread intracranially. You're talking cavernous sinus thrombosis, brain abscess, really nasty complications.
So the presentation clinically, we're looking for redness, severe pain, lots of swelling, maybe a fever. But what's the absolute red flag sign that says, admit now?
It's the proptosis, that forward bulging of the eyeball. If you see that, it confirms the infection is posterior, pressing on everything inside the orbit.
That makes sense. So if you, as a GP trainee, see someone, child or adult, with those signs, especially proptosis, what's the immediate plan?
Immediate admission. Simple as that.
Yeah.
Your job in primary care is basically stabilize and get them transferred fast.
Right.
They need 5E antibiotics straight away, sometimes steroids to get the swelling down, and often they'll need urgent surgical drainage if there's an abscess.
You'd be checking vision, pupils?
Constantly, yeah. Any deterioration means the pressure's rising. If you're somewhere remote, maybe get IV access, get blood cultures done before they go. Just saves time at the hospital end.
Okay, critical stuff. Moving on from infection to the vessels. Retinal vascular occlusions. This is classic exam territory, isn't it?
Yeah.
Making you differentiate artery occlusion, RAO, from vein occlusion, RVO.
Absolutely. Both tend to cause sudden, painless vision loss, often in older people, but that's kind of where the similarity ends. The pathology, the urgency, the systemic implications, totally different ballgame.
So let's start with the artery central retinal artery occlusion, RAO, the eye stroke.
Exactly. It's sudden and critically, it's painless. Usually an embolus or thrombus blocking the main artery supplying the inner retina.
And the fundoscopy finding. This is one everyone remembers, right?
Oh yeah, the classic cherry red spot. You see this pale ischemic retina because there's no blood flow, but the fovea, which gets its supply from the choroid underneath, stays red. Creates that stark contrast.
And if it's the central artery, it's complete vision loss.
Pretty much. If it's just a branch, you might get a sector defect, like losing the top half of your vision or something.
What's the urgency like for RAO? How fast do we need to act?
Extremely urgent. The retina only lasts maybe a couple of hours with no blood supply before the damage is permanent. Our sources say you need to be thinking about treatment within hours.
Wow.
Now, definitive treatment in ophthalmology is tricky. Sometimes they try to dislodge the clot by rapidly lowering eye pressure, maybe IV acetazolamide or even ocular massage.
Does it often work?
Honestly, often not, but you absolutely have to try, and try immediately.
But the thinking doesn't stop at the eye, does it? This is the big GP take-home message. And RAO is like a TIA of the eye. So what happens next for the patient?
All right, this is crucial. You need an immediate, full-on CVD risk assessment. You have to assume this could be a warning shot for a major stroke.
So admission or urgent TIA clinic?
Admission is often safest, or at the very minimum, TIA clinic review within 24 hours, even if the vision seems to come back.
Yeah.
They need carotid Dopplers, ECG for AFib, start high-dose aspirin straight away. You're basically diagnosing major stroke risk by looking in the eye.
Okay, huge implications. Now let's contrast that with retinal vein occlusion, RVO. Again, sudden, painless vision loss, often older person.
Yeah.
But it's about drainage, not supply, right?
Exactly. RVO is usually caused by back pressure, congestion, often where a stiff artery squashes the vein where they cross. That's AV nicking.
And the fundoscopy reflects that congestion.
Totally. It's that dramatic stormy sunset or smashed tomato look, really hemorrhagic, messy, loads of blot hemorrhages everywhere, very different from the pale RAO picture.
And the main risk factors for RVO that we manage in primary care?
Number one is hypertension, then glaucoma, and conditions that make the blood thick, like polycythemia.
Is it as urgent as REO?
It's still an emergency, definitely needs admission for assessment and to rule out complications like neovascular glaucoma, but the immediate irreversible damage timeline is usually a bit longer, think days rather than hours, usually. Management involves treating things like macular edema with anti-VEGF injections or laser.
So the key exam differentiation, REO, pale fundus, cherry red spot, immediate stroke workup, RVO, hemorrhagic fundus, stormy sunset, managed H-teen glaucoma, slightly less immediate urgency, but still an emergency.
You've got it. Perfect summary. Okay, moving on, let's talk about mechanical separation. Retinal detachment, RD. This is when the inner retina peels away from the back of the eye and fluid gets underneath.
How do patients usually describe this? What's the classic symptom?
It's painless.
Yeah.
And the absolute classic is that feeling of a curtain or shadow coming down or across their vision. Often they might have had warning signs for weeks or months before flashes of light, photopsia, or new floaters.
And on exam, maybe vitreous floaters or an asymmetric red reflex.
Exactly. And you need to ask about risk factors, any recent trauma. Cataract surgery, are they very short-sighted, high myopia, family history?
Right. Now, there's a really critical distinction the exams love to test regarding flashes and floaters.
Ah, yes, the PVD versus RD question. This is vital for triage. If someone comes in with flashes and floaters, and this is the key, their visual acuity is completely normal and there's no field defect.
That is probably not RD.
Exactly. It's overwhelmingly likely to be a posterior vitreous detachment, PVD. That's just the jelly inside the eye shrinking and pulling away from the retina. Much more common, much more benign.
Although PVD can sometimes cause a tear that leads to RD.
It can, which is why they still need checking.
Yeah.
But PVD itself isn't RD. RD needs urgent surgery, laser, or vitrectomy to stick the retina back down.
Okay, that's a super important point. And briefly, vitreous hemorrhage, VH.
That's bleeding into the vitreous jelly. Presents often with a sudden shower of floaters, sometimes described like soot, and painless vision loss. Needs admission to find the cause, could be trauma, leakage from an RVO, or very commonly leaky new vessels from diabetic retinopathy.
Okay, red eye. Probably the most common eye thing we see in GP, right? But the challenge is sorting the simple stuff from the really sight-threatening inflammation or infection.
Yeah.
Let's start with episcleritis versus scleritis. The sources say it hinges on pain and that blanching test.
That's right. Let's start superficial episcleritis. Inflammation of the very outer layer of the white part, the sclera. Patients usually report discomfort, maybe a bit of an ache, gritty feeling, but critically, it tends to get better on its own in, say, 7 to 10 days.
And the vessels are superficial, so the blanching test.
Exactly. If you put gentle pressure on the eyelid over the red area, or use a vasoconstrictor drop like phenylephrine if you have it, those superficial vessels blanch. They temporarily disappear or go white. That tells you it's superficial.
And the systemic link we need to remember for episcleritis, especially for exams.
Classically linked with inflammatory bowel disease, IBD, Crohn's, or UC, sometimes rosacea too. Management is usually just reassurance, maybe some topical NSAIDs or mild steroids for comfort, but it generally sorts itself out.
Okay, simple enough. Now, the serious one, scleritis, full thickness inflammation.
Yeah, this is a whole different beast. The pain is usually intense, deep, often described as a really boring, radiating ache. Can wake them up at night. The redness is deep, often purplish.
And the blanching test here.
The vessels do not blanch. Because the inflammation is deep down in the sclera, pressure or drops won't make them disappear.
And the systemic links are much more worrying here.
Hugely worrying. Scleritis is often a sign of a severe underlying systemic autoimmune disease. Top of the list is rheumatoid arthritis, RA, but also things like lupus, SLE, or Wegener's, GPA. If you diagnose scleritis, you're potentially flagging up a major systemic illness.
So treatment is systemic too.
Absolutely. High-dose oral NSAIDs, sometimes steroid injections near the eye, or even starting DMARDs to control the underlying disease and stop the sclera thinning or perforating.
That difference, Epi. Superficial blanches, ache, IBD link versus scleritis. Deep, non-blanching, severe, boring pain, RA link. That's a crucial safety distinction.
Totally. Now, shifting to infection, the big red flag with corneal ulcers. The herpetic or dendritic ulcer from herpes simplex virus, HSV.
Patient comes in, sensitive to light, eye watering like crazy, feels irritated. How do we confirm it's HSV?
You need fluorescein stain. Put a drop in, look with a blue light often on your ophthalmoscope, and you'll see the classic pathognomonic pattern. A branching fern-like shape, that's the dendritic ulcer, confirms active viral replication on the cornea.
And this leads us to probably the single most important management warning in this whole topic.
Yes, absolutely critical. Do not give steroids. Cannot emphasize this enough. It's a major exam safety point and a clinical disaster waiting to happen.
Why are steroids so bad here?
They suppress the local immune response. The virus then just goes wild, replicates uncontrollably. The dendritic ulcer can rapidly expand into a much larger, amoeba-like geographic ulcer. This causes massive scarring, thinning, potential corneal melt, permanent vision loss.
So the treatment must be antiviral.
Only antiviral. Topical aciclovir ointment, usually. Mistaking this for non-infectious inflammation and giving steroids is a catastrophe.
A real test of safe prescribing.
Yeah.
Okay, finally in this section, just a quick reminder of the reactive arthritis triad.
Yeah, the old mnemonic. Can't see, conjunctivitis or sometimes uveitis. Can't pee, urethritis or cervicitis. Can't climb a tree, arthritis, joint pain. It's that post-infectious inflammatory response, often after a GI or GU bug, reminds you to look beyond the eye.
Right, let's move on to chronic conditions, things that cause gradual vision loss or show long-term systemic damage in the eye. Top of the list has to be age-related macular degeneration, ARMD.
Definitely. Affects the macula, the central bit of the retina needed for detail reading faces. It's the biggest cause of central vision loss in older people in developed countries.
Pathology is age-related changes, those yellow deposits called drusen. But we split it into two main types, right? And that dictates urgency.
Absolutely. You've got dry ARMD, that's the vast majority, maybe 80–90%. It's gradual, caused by thinning or atrophy of the retinal layers. Vision loss is slow.
And then there's wet ARMD.
Yeah, wet or exudative ARMD. Much less common, but much more severe. This is where abnormal blood vessels grow under the retina choroidal neovascularization. These new vessels are leaky, they bleed and ooze fluid, causing sudden, often dramatic central vision loss. Wet ARMD needs urgent referral to ophthalmology.
Okay, urgent referral for wet. And risk factors are key for counseling. Age is the big one, obviously, but what's the major modifiable risk?
Smoking, absolutely number one. Increases the risk of wet ARMD massively, maybe threefold. Also hypertension, cardiovascular disease history. Quitting smoking is vital.
And the symptoms patients complain of. Blurred central vision, difficulty reading. But what's the really characteristic symptom?
Metamorphopsia. That's where straight lines look wavy, bent, or distorted, like looking through water. It's caused by the fluid or blood lifting the macula.
And that distortion is what we pick up with the Amsler grid in clinic.
Exactly. Simple grid of straight lines, central dot, cover one eye, look at the dot, ask, are any lines wavy, missing, broken? If they say yes, especially if it's new or sudden, that strongly suggests macular trouble, like wet ARMD. Needs that urgent referral.
We also mentioned Charles Bonnet syndrome briefly. Was that again?
Yeah. It's fascinating. Happens when people lose significant vision, often from ARMD. They start having complex visual hallucinations, seeing people, animals, patterns that aren't there. But, and this is key around, they know it's not real. They have insight.
So it's not psychosis?
No, not at all. It's thought to be the brain basically filling in the gaps from the lack of visual input. Just knowing the diagnosis is hugely reassuring for patients they're not going mad.
Management for wet ARMD is mainly those anti-VEGF injections, like ranibizumab, to stop the leaky vessels, plus lifestyle changes, visual aids.
That's the mainstay, yeah. Okay, next up, cataracts. And specifically for exams, those post-op complications and their timelines.
Right. Cataracts themselves, cloudy lens, mostly age-related. But what are the high-yield systemic causes exams might test?
Good question. Definitely diabetes, long-term high-dose steroid use, previous trauma to the eye, also hypocalcemia and hypothyroidism, worth remembering those.
And management. Routine referral for adults usually, but kids.
Children with congenital cataracts need urgent referral. Delay can lead to permanent lazy eye amblyopia, so that's a key difference.
Okay, now let's nail these post-op timelines. This is pure gold for AKT questions. Patient had cataract surgery. Presence with sudden, severe pain, redness, blurred vision just a day or two later. What is it?
That's endophthalmitis, infection inside the eye, absolute emergency, sight-threatening, needs immediate hospital admission, likely intravitreal antibiotics, maybe a vitreous tap. Don't sit on that one.
Okay, immediate post-op pain redness and endophthalmitis. What if the blurred vision, maybe mild discomfort, comes on weeks later, say 4-6 weeks post-op?
That timeline points towards cystoid macular edema, CME, swelling in the macula due to leaky capillaries, often inflammatory post-op. Less acutely severe than endophthalmitis, often responds to topical NSAIDs or steroid drops, but still needs ophthalmology review.
Right. And the most common thing happening months later, patient says vision was great, now it's getting blurry again gradually.
That's almost certainly posterior capsulopacification, PCO, sometimes called after cataract. The thin membrane behind the new lens implant gets cloudy. Very common, painless. Needs a quick, simple outpatient laser procedure, YAG capsulotomy to clear it.
And don't forget, retinal detachment is also a long-term risk post-surgery.
Good point, yes.
Okay, those timelines are key. Leads us nicely into the systemic diseases showing up in the eye, the retinopathies.
Yeah, the eye really is a window, isn't it? Diabetic retinopathy is the big one. Damage to the small vessels from high sugar levels leads to hemorrhages, leaky spots called exudates, and eventually abnormal new vessel growth, neovascularization, which can bleed badly.
Management is all about controlling the diabetes and blood pressure.
Ah.
Plus, laser, anti-VEGF if it gets advanced.
Exactly. And the crucial GP role.
Making sure they go for their annual screening every single year. Catching changes early is the only way to prevent blindness.
Absolute vital. Similarly, hypertensive retinopathy. Sustained high BP damages the retinal vessels too. We look for specific signs on fundoscopy.
Like AV nicking.
Yeah, where arteries indent the veins they cross, silver wiring of the arterioles as they harden, flame hemorrhages, cotton wool spots, and in really severe malignant hypertension, you can get papilledema optic disc swelling.
And management is just treat the blood pressure aggressively.
Pretty much. The eye signs reflect the damage happening elsewhere. Brain, kidneys, get the BP down.
2 quick ones to finish this section. Graves' disease in the eyes.
Right. Thyroid eye disease or thyroid-associated orbitopathy. Autoimmune attack on the TSH receptors in the eye muscles and fat. Causes proptosis, double vision from restricted movements, potentially optic nerve compression. Treatment involves steroids, sometimes radiotherapy or surgery. But the single most important piece of advice from a GP...
Stop smoking.
Absolutely. Smoking makes thyroid eye disease massively worse and less responsive to treatment. Critical advice.
And finally, retinitis pigmentosa, RP.
This is a group of inherited conditions causing progressive retinal degeneration. Key things to ask about. Difficulty seeing at night. Night blindness often starts early. Then gradual loss of peripheral vision leading to tunnel vision.
And the classic fundoscopy finding.
Those characteristic bony spicules black pigment clumps out in the periphery of the retina. Very distinctive. Sometimes linked to other conditions like Alport syndrome, kidney problems, hearing loss.
Okay, here's where it gets potentially quite tricky but also fascinating. Neuro-ophthalmology. Really tests your localization skills. The absolute foundation is knowing that cranial nerve map for eye movements, LR6, SO4, 03.
Yeah, that mnemonic is just indispensable, isn't it? You need to recall it instantly. So LR6, lateral rectus muscle, moves the eye outwards, abduction, supplied by the sixth nerve, the decussins. If that's out, the eye can't look outwards properly, causes double vision worse on looking to that side.
Okay, and SO4.
Superior oblique muscle. Its main job is moving the eye down and in, supplied by the fourth nerve, trochlear. A fourth nerve palsy often makes reading or going downstairs difficult. Patients might tilt their head to compensate for the double vision.
Right. And O3, the third nerve, oculomotor, does everything else.
Pretty much all the other muscles, plus it lifts the eyelid and controls the pupil size. So a complete third nerve palsy is dramatic. What's the classic picture?
Eyes down and out, because LR6 and SO4 are still working at opposed. Big ptosis, eyelid completely shut. And crucially, the pupil is dilated and fixed.
Exactly. And that pupil involvement is the emergency sign. Why?
Because it suggests compression. often from a posterior communicating artery aneurysm pressing on the nerve fibers that control the pupil. Needs urgent neurosurgical assessment.
That's the life-saving bit. If you have a third nerve palsy but the pupil is spared, reacts normally, it's more likely due to something like diabetic microvascular damage. Still needs investigation, but less immediately terrifying than an aneurysm.
Okay, vital distinction. Now let's tackle specific pupil disorders. 3 high-yield ones. First, the famous Argyll-Robertson pupil.
Ah, yes. The mnemonic some people use is prostitute's pupil, accommodates but doesn't react.
Or maybe slightly less memorably, accommodates but reacts poorly to light. ARP.
Okay, ARP works too. The pupil constricts when the patient focuses on something close, accommodation, but it doesn't constrict when you shine a light in it, light reflex is gone. Pupils are often small, irregular, usually both sides, and the classic association.
Tertiary syphilis, neurosyphilis, high-yield link.
Absolutely. Now contrast that with the Holmes 80 pupil.
Different kettle of fish entirely.
Completely. This is usually benign, often in young women. It's typically one large, irregular pupil that reacts very slowly, almost vermiformly, to both light and accommodation. Often associated with absent ankle or knee reflexes, needs recognizing but doesn't scream systemic disease like Argyll-Robertson.
Right. And the third key one, Horner's syndrome, interruption of the sympathetic nerve supply.
Yeah, Horner's is a big diagnostic sieve. You see that classic triad. Slight pitosis, mild lid droop, meiosis, constricted pupil on that side, and anhidrosis, loss of sweating on that side of the face.
Wow.
And the causes.
Could be anything from benign things to really serious stuff.
Right.
What are the red flag causes we must rule out?
Top of the list, Pancoast tumor, lung cancer at the apex, pressing on the sympathetic chain, neck trauma, thyroid surgery complication, or, critically, an underlying carotid artery dissection. That's an emergency.
So if you see Horner's, you need to investigate urgently for those causes.
Yeah.
Okay, let's move on to the real puzzle. Visual field defects. Linking the pattern of loss to where the lesion is in the brain.
Right. General rules first. If the loss is central, think optic nerve or macula ARMD, optic neuritis maybe. If it's peripheral loss, think glaucoma, RP, maybe RVO.
But if the loss respects the vertical midline, we're thinking behind the chiasm. What about bitemporal hemianopia, losing the outer half of vision in both eyes?
Classic pituitary tumor pressing on the optic chiasm, where the nasal fibers carrying temporal field info cross over. That crossing point gets squashed.
Makes sense. And homonymous hemianopia, losing the same side in both eyes, like the whole right field is gone in both the right and left eye.
That means the lesion is after the chiasm on one side. Could be the optic tract, the optic radiations deeper in the brain, or the visual cortex in the occipital lobe. Stroke is a common cause.
And this is where those mnemonics become essential to pinpoint it further. Let's slowly unpack the PITS mnemonic for the quadrantinopias. People find this confusing because the lesion seems opposite to the loss.
Okay, visualize the optic pathways radiating back. The fibers carrying info from the inferior visual field sweep upwards into the parietal lobe. So, PITS, parietal lesion causes inferior quadrantinopia, loss of the lower field.
So can't see the floor properly, damage is high up in the parietal lobe.
Exactly. Conversely, the fibers carrying info from the superior visual field loop downwards into the temporal lobe. That's Meyer's loop. So PITS, temporal lesion causes superior quadrantinopia, loss of the upper field, often called a pie-in-the-sky defect.
Okay, PITS, parietal inferior, temporal superior. Got it. Now, what about the CIPS mnemonic for refining lesions at the chiasm?
Right. This helps with bitemporal quadrant defects. A craniopharyngioma is typically a tumor above the chiasm, pressing down first on the inferior crossing fibers. So CI, craniopharyngioma, causes inferior bitemporal quadrantinopia.
And the more common pituitary tumor.
That usually grows up from below, pressing first on the superior crossing fibers. So PS pituitary causes superior bitemporal quadrantinopia. These help you predict the likely cause before the scan.
Clever stuff. And one final key fact about localization. Macular sparing.
Ah, yes. This means someone has a big field defect, like a homonymous hemianopia, but the very central pinpoint of vision is still working. This strongly points to a lesion in the occipital cortex itself, often a stroke.
Why does that happen?
Because the very back part of the occipital lobe, representing the macula, often has a dual blood supply from both the middle and posterior cerebral arteries. So it's more resistant to being completely knocked out by a single vessel blockage affecting the surrounding cortex.
Okay, let's wrap up with some really high-yield differentials and management points that kind of bridge the eye exam back into general practice.
Starting with the absent red reflex. Simple test, but crucial findings.
Yeah, fundamental, especially in kids. In an adult, if that red glow isn't there, you're thinking something major blocking the light path. A really dense cataract, a retinal detachment, or a big vitreous hemorrhage.
But in a child, the priority is different, isn't it? Massively different. While those adult causes can happen congenitally, the absolute number one thing you must rule out is retinoblastoma, the most common eye cancer in childhood. Any hint of a white reflex leukocrine instead of red is an immediate, urgent referral to ophthalmology. No delay.
Okay, crucial point for pediatric checks. Next up, differentiating transient vision loss. Amaurosis fugax versus retinal migraine. It's all about the patient's risk profile, right?
Exactly. Amaurosis fugax, AF, is that classic curtain coming down over one eye, last minutes, then lifts. It's a TIA of the retina, usually emboli from the carotids or heart. Because it's vascular, what's the immediate first step?
Give aspirin, 300 milligrams stat, assuming no contraindications.
Perfect. And then the TIA clinic referral. What are those crucial timelines the AKT loves?
Okay, if the AF happened less than 7 days ago, they need to be seen in the TIA clinic within 24 hours. High early stroke risk.
Yep.
If it happened more than 7 days ago, the immediate risk is a bit lower, so review within 1 week. That 7-day cutoff and 24-hour window are key.
Absolutely mandatory knowledge. Now, how do we distinguish that high-risk AF from the much less worrying retinal migraine? All right.
Retinal migraine can sound similar, transient visual disturbance, maybe shimmering lights or patterns in one eye, but the patient profile is different. Typically younger, often has a history of migraines, and crucially does not have those CVD risk factors like hypertension, AFib, smoking, etc.
And management is conservative.
Yeah, manage the migraine itself. No need for the urgent TIA workup if it fits the RM picture clearly.
Good. Now, clarifying two conditions involving pressure. Papilledema versus glaucoma. Similar sounding maybe, but totally different causes.
Right. Papilledema is optic disc swelling because of raised intracranial pressure, ICP. The problem is above the eye brain tumor, malignant hypertension, venous sinus thrombosis, even severe cochlear retention. Vision might actually be okay initially, needs urgent brain investigation.
Whereas glaucoma.
Glaucoma is optic nerve damage, usually due to raised intraocular pressure, IOP. The pressure problem is local to the eye. Damage is peripheral vision first, causing tunnel vision. Fundoscopy shows optic disc cupping, not swelling. Different pressure source, different pathway.
Exactly. Quick recap of optic neuritis, just because of its strong systemic link.
Okay, inflammation of the optic nerve. Classic presentation. Pain on eye movement, rapid loss of central vision, often reduced color vision too. And the key sign on examination.
The gun pupil, or relative afferent pupillary defect, RAPD, shine the light back and forth between the eyes. The affected pupil constricts less well, or even dilates slightly compared to the good eye.
And the big association.
Multiple sclerosis, MS. New onset optic neuritis often warrants an urgent MRI of the brain and spine and consideration of high-dose steroids. Strong predictor of developing MS later, if not already diagnosed.
Right. Finally, as GPs, we're involved in driving safety. Let's lock down those basic DVLA visual standards.
Okay, for Group 1, cars, motorbikes, you need to be able to read a number plate at 20 meters, which roughly equates to vision of 612 Snellen acuity with both eyes open, or in your only good eye if monocular.
And Group 2, lorries, buses.
Much stricter. Needs 67.5 in the better eye and 660 in the worse eye, plus specific visual field requirements.
And what kind of eye conditions mean someone definitely shouldn't be driving and needs referring for assessment?
Any sudden significant loss of vision that isn't transient, any new significant loss of visual fields that could impair safety, conditions causing double vision, diplopia that isn't controlled, or things like severe blepharospasm where they can't keep their eyes open reliably, all need formal ophthalmology assessment of fitness to drive.
Okay, and just to quickly circle back on those systemic links, Down syndrome.
High incidence of refractive errors, need glasses, also cataracts, keratoconus.
And rheumatoid arthritis again, beyond scleritis.
Very strongly linked with keratoconjunctivitis, sicca, really severe dry eyes, part of Sjogren's syndrome often. Also corneal thinning sometimes. These little links add depth. Hashtag tag outro. So just to kind of pull that together, The absolute key for navigating eye conditions, especially under exam pressure, is getting that hierarchy of urgency right. You have to instantly recognize and prioritize things like orbital cellulitis, retinal artery occlusion, wet ARMD, those are the can't-miss emergencies.
Mm-hmm.
Then it's about mastering those diagnostic clues, the blanching test for scleritis, the Amsler grid for ARMD, those neuronemonics like PIT, and definitely those classic fundoscopy patterns for the occlusions. But maybe the biggest take-home message is that the eye isn't separate. It's constantly reflecting cardiovascular health, autoimmune processes, neurological status.
So what does this all mean? I guess the final thought, building in what our sources suggest,
Mm.
is that when you find these specific ocular signs, maybe the cholesterol embolus, Hollenhorst plaque that caused amaurosis fugax, or the hypertensive changes on fundoscopy, or the painful eye movement and optic neuritis, these aren't just eye problems. They're often the very first clue, the most easily visible sign of a huge underlying systemic issue like stroke risk, MS, uncontrolled RA.
Yeah, absolutely.
So given how clear and critical these signs can be, maybe the question for you listening is, how much should finding something on a routine GP eye check actually change your threshold for investigating other seemingly unrelated systemic symptoms?
Hmm.
Because that eye exam might just be your earliest warning for something much bigger. It's looking at their vascular future, not just their vision.
Well said.
We really hope this deep dive has given you some solid practical knowledge for your exams and your practice.
Yeah, best of luck with the AKT and everything beyond.
Farewell.